Well, 2018 was, in a way, the year of the AAA guidelines. It started with the guidelines from SVS in the beginning of 2018, and we came up with the ESVS guidelines end of 2018 with a new body of evidence in different ways. We were able to be more granular in terms of screening, in terms of surveillance, and also in terms of operating tactiques. So there are specific new details came up for the ESVS guidelines, which make them very worthwhile to read. So mainly, the majority of recommendations are quite similar. We adhere to another grading system, but overall the main thresholds and main recommendations are found on a sound body of evidence and are quite similar. However, there are specific details which are more specific for the European countries than compared to the American. Well, the ESVS guidelines are very detailed and are founded on a very sound body of evidence and huge references. It actually accumulates in a very political statement in terms of centralization of AAA treatment. The ESVS guidelines are very detailed and say a center should at least perform 30 procedures a year. Otherwise, we think the experience is not large enough to perform AAA treatment either via EVA or open repair with a reasonable mortality rate. Of course, it is always an issue to transfer theory of guidelines into clinical practice. So it is very essential that national societies will adhere these guidelines, and the body of evidence and recommendations are possible to be transferred into daily practice here. This is a task and a demanding task because policies differ in terms of healthcare systems and so on. The intention for these guidelines is to make them inherent to the global situation, actually. So every country should adhere to these guidelines. However, we are realizing that this is an obstacle and a major demand because healthcare systems are very different and needs are different and opportunities differ from country to country. So we tried to be as open as possible to make these guidelines possible to use for every country. There is one problem in terms of indication of different techniques. Still, EVAR is the first choice in good candidates with a reasonable surveillance. However, all these studies are quite old. They were conducted with devices which are old, which are outdated today. So the newer devices are probably even better. On the other hand, open repair techniques are also better than 20 years ago, and the centers adhere to higher standards, aiming to a less mortality rate after open repair. So we possibly need new evidence with current practice to renegotiate whether EVAR or open repair should be offered as the first choice to our patients.